So I have one confession to make, and I can't help myself to say this. Seems like everybody I meet, I don't love California, and I'm very much a New Yorker, and I have to say, even though I didn't grow up in New York, I say to myself, I'm never going to come back out to California again. I'm just not going to do it. But I have to say, and Amanda, my former postdoc who's sitting in the front row, and David are two of the reasons why when I got this invitation I came. But I also have to say the memory of the last time at this specific place is really so great that every time I come here, I think, California still might not be the best place, but the Mind Institute, Davis, and Sacramento is really a wonderful place. So it really is. It really is. And it doesn't feel like California either. So, and one of the things that's really great is the science here, and really many aspects of the science are really great. And so it's very fun to come here and to be able to give you kind of my freshest ideas and really look for, I know the last time I was here, I got a lot of great, I don't know if I would call them questions, but grilling. I got a lot of great grilling. So I really look forward to some great grilling. So in terms of disclosures, I had a lot of great disclosure jokes, but I've told them so many times, I can't tell them anymore. I don't have any, except probably the only thing to say is that I'm going to be talking a lot about therapeutics. Nothing that I'm going to talk about should in any way be construed as ready for treatment in the clinic. But the approach that I'm going to talk about, and again, you'll hear more about that in a couple of minutes, hopefully will be kind of a hint of what's to come in terms of the future of therapeutics. So I'm going to try to end really right exactly at 5:30, no later than 5:30, and leave a full half hour for questions. And I'm really going to do three things. I'm going to give you kind of a broad overview introduction, and then I'm going to talk about two specific examples about where neuroscience is just beginning to generate ideas about novel therapeutics. And work in pediatric anxiety disorders is very good for some things, not so good for other things. But the one thing that it is really good for is kind of stimulating ideas about how neuroscience might become clinically relevant. And I think that's the thing, as a clinician who's interested in neuroscience, that's the thing that I think a lot of us are struggling with. When is the day that neuroscience will be clinically relevant? And I think that day is very far away. But I do think, again, that some of the first hints are going to come from part of the story that I'm going to tell you. All right. So the thing that my group does is we study individual differences in anxious behavior. And there are three sets of neuroscience kind of questions that we explore. Questions about specificity, questions about differentiating risk from disorders, and questions about generating novel treatments. And the idea in all this work that we do is that we want to use neuroscience to answer primarily clinical questions. And so we want to link what we know about the brain to what we know about clinical features. And then the way that we think about this, link is that we want to study individual differences in brain function, and we're particularly interested in amygdala prefrontal cortical functions, and we really want to link them to clinical features, anxiety disorders. And one of the great mistakes of psychiatry from the mid-1980s through the mid-2000s is to really think that the current phenomenology that we have and the categories of problems that we see is going to have any kind of tight link to neuroscience. That's clearly not going to be the case. And if we hope to link the brain to clinical entities, we're going to fail, and we've failed before we even begin. So the way that we think about it is that we focus on something that we call disruptions in core psychological processes. And what these are will become clearer as I talk about two of them. But the idea is that we're going to select these, first of all, by thinking about what we know about the brain and where are there behaviors and associated computations where we have very precise mappings in terms of the link between individual differences in behavior and the individual differences in the brain. And from among the many different things that we can select, we're going to choose that subset where there is also a link clinically. So you can almost think of this as a slip knot, that we have a slip knot here that really is centered on this idea of core psychological processes that are equally balanced in terms of the evidence that links them to a brain-behavior relationship and to clinical disorders. And pretty much all of them that we study are in the area of attention and memory, and I'm only going to really be talking about 2 of the many that we study. And a lot of people want to know, well, how do these things really map onto disorders? And that's something that, again, I'm not going to talk about. I have a talk that I give just about that. The 2 things to say, though, it's not going to be a one-to-one mapping, and the way we think about nosology and diagnosis is going to be very different, I'm sure, in 10 or 20 years. So that's number 1. And then number 2, we're going to have to start thinking about kind of piecing together different psychological processes, almost like a jigsaw puzzle, to try to understand how brain dysfunction relates to disorders. And some of these things are going to be disorder specific, and as I mentioned, my group spends a lot of time studying these disorder specific processes. I'm actually not going to talk about any of them today. The processes that I'm going to be talking about today are disorder general, and when I mean disorder general, they're really found in all of the anxiety disorders. Probably not in the mood disorders and not in the psychoses, but really all of the anxiety disorders. So clearly they don't map on to nosology. And the thing that really separates not only the 2 things that I'm going to be talking about today, but all the work that we do, is it really kind of rests like a fulcrum on kind of studying behaviors, very specific behaviors, both clinically and neuroscientifically. And these are the 2 that I'm going to talk about. First I'm going to talk about conditioning, and then I'm going to talk about attention disruption. Now, as I mentioned, we're interested in amygdala prefrontal connections, and whenever I show this slide, particularly in front of David, I have to remind everybody, including myself, I am a psychiatrist, so I'm not an anatomist on the one hand, but it's a little bit like, my mother used to say about me as a baseball player. I thought I was really a pretty good baseball player. My mother used to say, for a Jewish kid, you really are a pretty good baseball player. So for a psychiatrist, I'm not a bad anatomist. So we are really interested in 2 sets of connections. And the behaviors that I'm going to be talking about do segregate in terms of the circuitry that we're studying along the anatomical substrata that Joel Price has mapped in terms of amygdala prefrontal connections. So I'm going to be talking about first medial prefrontal amygdala connections related to conditioning and extinction that you can see in this red network. And then in the last part of the talk, I'm going to be talking about lateral amygdala prefrontal connections through that lateral network. And again, as I mentioned, my group really works on 3 things. The only thing I'm going to talk about today is generated novel treatments. And again, I'm going to talk about neuroscience, and I'm going to try to show you how neuroscience generates ideas about novel treatment. All right, so that's number 1. Conditioning and extinction. So everybody knows what fear conditioning is. It's the pairing of a neutral stimulus, such as the sound. I always got a kick out of that poor mouse whenever I show this. But that sound with that shock. And so when you pair this sound with the shock, the organism develops fear to that neutral stimulus that has always been a neutral stimulus. So ever since, for the last 21 years since I've been in this field, everybody has thought that studying fear conditioning is the key to understanding the anxiety disorders. And everybody's been convinced of it, and there's a lot of reason to be enthusiastic about it, not the least of which is when you think about these brain behavior associations, probably none of them have been mapped more precisely than fear conditioning. The problem is that when you start looking at the literature, there is absolutely no evidence that when we look at the most robust, clearest, least ambiguous measures of fear conditioning, there is no evidence that fear conditioning is abnormal in the anxiety disorders. Anxiety disorder patients conditioned to CS stimuli relative to CS minuses, absolutely the same as healthy subjects, which is a big problem, all right? And it's a problem that people have not really wanted to state as directly or as explicitly as I have. And the reason why is that when you look at fear conditioning paradigms, there are subtle hints that there are problems in the way that patients with anxiety disorders learn about fear, but you would not describe them as a primary abnormality in fear conditioning as we usually think about it in the response to the CS plus relative to the response to the CS minus. So how do we think about it? Well, we would think about it the way that I think about it, and I'm going to tell you a little bit about this. We would think about it as a perturbation in drawing the boundary between where safety ends and danger starts. That's really the problem, that there is a broadening, and I'll show you one specific example of this in a second, so it'll become clearer. It is a broadening of where patients make that cut in terms of when safety ends and danger starts. But that's really what the problem is. And that's really how we should understand it. And it happens both in what I call object-related and time-related domains. And again, I'm going to tell you what I mean about that right in a minute. To understand this idea of broadening, you need to first think about this object-related domain and making a classification of objects as safe and dangerous. And you need to think about something called generalization and a generalization gradient. It's something that Pavlov, many others have described. This is a paper from the 70s that conditioned pigeons with red light. Red light was the CS plus. And what it did was it conditioned the pigeons with the red light, and then it looked at their responding as light went from red to orange to green. And you can see that pigeons have this very abrupt fall off. This is what we think we see in the anxiety disorders. There is a stronger generalization gradient that is this trouble distinguishing. We don't think that they respond abnormally to the CS plus, all right? So one of many studies that I'm just going to show you one study, but it's many studies in this area that we've done, uses a fear conditioning paradigm in adults with, we've done it with many different anxiety disorders. I'm just going to show you this one study in 19 panic disorder patients and 19 healthy subjects. And this is work primarily done by Shmuel Lissick and Christian Grion with me and others. And subjects were conditioned to either a large circle as the CS plus and a small circle as the CS minus, or a large circle as the CS minus and a small circle as the CS plus. And they were conditioned just like every classical fear conditioning study is done. The thing that was novel about this study is after conditioning, patients were also exposed to these different gradient circles, which were never reinforced with a shock. The CS here was a shock. And what you can see, and the evidence was quite dramatic across many different measures of physiology, measures of perceived risk, measures of reaction time, that the fall off, much like those pigeons in the healthy subjects, between the response to the CS plus and this gradient was steeper in the patients than it was in the healthy subjects than it was in the patients. Consistent with this idea that patients are, if anything, even reduced on some measures to the overt threat, but their problem is telling the difference between when the threat ends. That's the fundamental problem that they have. So I did a lot more work in that I'm not going to talk about. The main thing that I've spent my time on for the last 5 years is, okay, if we believe that idea in adults, how are we possibly going to do this in kids, and why is this clinically relevant? Why does this have anything to do with anything? So I'm going to talk about really the two things that we've done. The first is selecting a UCS. All the work that we do in adults is with a shock UCS. It works great. And since I am from New York and I'm in the name of full disclosure, I did briefly consider doing a series of studies of shock in children, and I said it's probably not a good idea, even in New York. But we spent a lot of time trying to come up with a good UCS, and we did a lot of studies in adults. And we came up with everything that we could think of. This just shows you some of them: white noise, loud sounds, sudden alarms, air puffs, bad tastes, bad comments, IAPS figures. And the UCS that we have found to work the best, that we've now done 6 or 7 studies with, I'm only going to tell you about 1 or 2, is the UCS is a woman who looks very afraid and then who lets out a blood-curdling scream. That is the UCS that we use, that I can absolutely tell you is completely ethically acceptable on the one hand, but as you'll see, a very potent UCS. The second thing we did is, remember I talked about object-related and time-related domains. We really want to study extinction, because one of the classifications that people with anxiety disorders have to make all the time is this time-related distinction between stimuli that used to be dangerous and they're not dangerous now. So they have to learn how to extinguish their fears. And that is another type of classification that patients have to make. So extinction refers to the process whereby a stimulus such as this light, again, it's paired with the shock, and then it's presented over and over again, and finally, over time, when there's no shock, the organism extinguishes, all right? That is another form of classification that we think is particularly relevant for development. And the reason we think that is if we look at the natural history of anxiety disorders, we see the following distribution. What you see is that anxiety disorders are extremely common. So this is a longitudinal study that I had the great luck of working on for about 20 years with 2 epidemiologists, Pat Cohn and Judy Brooke, and we followed about 700 kids all the way through adolescence, repeatedly assessing their anxiety disorders, and then looking at the relationship between anxiety disorders in children and either mood or anxiety disorders or any emotional problem in adults. And what you see there is you see that anxiety disorders are extremely common on the one hand. On the other hand, most of them are transient. Of the 253 kids who had an anxiety disorder, 191 of them had no problem when they were adults. But number 3, the most important point is, of the 98 afflicted adults, 62 of them had their problems start when they were kids. So the majority, the 2/3 of chronic mood and anxiety disorders in adults actually start as pediatric anxiety disorders. Not a transient form of pediatric anxiety disorders, but a persistent one. So we can think of these kids as the kids who developed an anxiety disorder who failed to extinguish their anxiety disorder. And if we can study extinction, both in a neuroscientific way, but also in a way that is relevant for therapeutics, maybe we'll learn something about treatment. All right, so that's what I'll just say a couple words about that. So I mentioned, we did the study with anxiety disorder patients. We used shocks and circles. So we wanted to look at this idea of generalization. So we took our CS that I told you about, our UCS, which is a scared person who lets out a blood-curdling scream, and rather than using circles that vary, what we did is we morphed these ladies. So you can see she is the CS plus or the CS minus for some people. She is this, again, either the CS plus or the CS minus for other people. And you can see that she gradually morphs across here. And we are doing a whole bunch of studies that are using not this approach that we do in adults, but this approach that we do in kids. So the idea is that you see a whole bunch of CS minus stimuli or CS plus stimuli without the UCS, and we condition using that scared lady with the scream. And again, we've done a whole bunch of studies with this. I'm only going to give you the bottom line. And the main thing that we do is that we condition people in the psychophysiology lab on day 1 using this experience, we extinguish them that same day. So everybody gets conditioned, everybody gets extinguished, all right? And then we bring them back anywhere between 15 and 400 days, and either in the psychophysiology lab or in the MRI scanner, we ask them a bunch of questions about these graded stimuli, all right? And we look at the degree to which they remember what happened, and we look at the degree to which they're afraid. And I'll just show you two findings from that. So the first one, I have to tell you, this is one of those findings that not only did I have the data analyzed like 4 times, I had the entire experiment done twice, because I still don't fully believe the findings. And so what we did, we brought kids back 400 days later, all right? So more than a year after they had this conditioning experience. And we showed them these morphs, and we said to them 2 things. Number one, which lady screamed? All right, which was lady screamed? Most of the kids said, lady screamed. I have no idea what you're talking about. I don't even remember doing this. And we said, just guess. Just guess which lady screamed. All right, and the other thing we asked them is, are you afraid? And why would I be afraid? You're just going to, yes, I realize that. If you're not afraid, you're not afraid. But just, say yes or no. Say the first thing that comes to your mind. So the amazing thing is, 400 days later, as you can see in this red line, these kids really remembered, even though they had no idea what they were doing. They really remembered. And when you look at the first 2 stimuli, where a year after conditioning, these are the 2 stimuli that these kids are telling apart, which I have to tell you, when I look at them, it's hard for me to tell them apart, even when they're right next to each other, relative to those, that's the CS plus and CS minus. The other really interesting thing is, this does not relate to how anxious the kids are at all. This does. How anxious you are at conditioning, as you might think, relates to how afraid you are at memory. The next thing that we've done is we've done this in the scanner, and you do see that there is a very robust activation in this ventral medial prefrontal region, specifically at the time when kids are monitoring their fear state, as a graded function of the degree to which this stimulus had CS plus features in it. And then the last thing to say, though, so the reason that this is really relevant to therapeutics, we know a huge amount about this process of extinction. And it involves this connection between this ventral medial swatch of that red network, extended at least from here all the way down, and its connection to the amygdala. We know that to successfully recall and extinguish CS, the organism must draw on the connection between that swatch of ventral medial prefrontal cortex and the basolateral amygdala. And we know a huge amount about the connections between those 2 brain regions. And this slide is really just designed to show you the complexity of those connections. And we know that, because we know so much about this, that we can, if we manipulate this receptor, the NMDA receptor, in a certain way, if people have a problem making this classification, we can increase the strength of their extinction process. So the idea is that if we could expose anxious children and adults to the things that they're afraid of as part of cognitive behavioral therapy, and we think about their category forming structure as in some way deficient, if we could boost the activity of that network, we might increase their ability to learn this distinction, a distinction that they really, that's the problem that they have. Well, so the amazing thing is there are lots of medications that do act as weak agonists on the NMDA receptor. And you can see that orange site right there is for one of these, D-cycloserine. And there are now about 10 studies that take adults, there's 1 study in kids, 10 studies in adults, that take anxious adults, expose them as part of cognitive behavioral therapy to the things that they're afraid of, as part of extinction. That's how we think cognitive behavioral therapy works. Half of them randomly are assigned to a placebo, and half of them are randomly assigned to receiving this medication, D-cycloserine, only at the moment of exposure, right? So this isn't like a medication that we usually prescribe, where you take it all the time and it treats your symptoms. This is designed to target this underlying problem that we think anxious people have in learning a difficult kind of classification, and there is emerging evidence to say that this might increase the efficacy of CBT. Now, the main thing to say about this is not that you should run out and get decycloserine, because the truth of the matter is there's probably a signal there, but it's not a huge signal. The more important message to say is this is one of the few examples where we really take a core psychological process, in this case, extinction of conditioned fear narrowly, but more broadly, making these difficult discriminations among safe, ambiguous, and threatening stimuli, and we use what we know about the neural circuitry, and we come up with a novel treatment that we think can work. And the great thing about that is decycloserine is just one molecule. There are many, many, many other approaches that we can take that really come right out of the neuroscience, all right? And this is the example, one example, of why neuroscience becomes clinically relevant. Neuroscience generates novel ideas about thinking about problems and coming up with new hypotheses about how to treat them. That doesn't mean we immediately run out and say, oh, gee, we've discovered the new treatment. Of course, we do the randomized controlled trials, but the idea is that these are new treatments that we would never have thought of before. All right? All right. So the last thing I'm going to do is I'm going to talk about attention. In some ways, the story is going to be very, very similar. In other ways, it's going to be radically different. So I'm going to switch gears. So it's similar in the following way. Much like we did when we talked about extinction of conditioned fear, we're going to select a very specific behavior, all right? And we're going to try to drill down very deeply into that behavior, and we're going to say, how does that behavior, and understanding the underlying neural architecture and the psychology of that behavior, how does that help us understand patients, and how does that lead to new treatment? And this is the behavior right here. And so the idea is that this guy's walking through the woods, he's engaged in not a very emotional process, and his attention is suddenly captured by this threat stimulus, all right? Joe Ledoux, writing in the 1990s, started talking about what we now call bottom-up capture of attention by threat. And yeah, one of the actually fathers, I won't say grandfathers, of research in this area is actually sitting in the front row, Dr. Andrews. And psychologists have been talking about the bottom-up capture of attention for 40 years. We now know from work in neuroscience, we know a lot about the underlying neural architecture of this. And the key idea that came from the neuroscience is that there are at least two components to this threat processing and capture of attention. One of these operates very rapidly, so you see that you get this crude picture of the snake here very rapidly, and another operates very slowly. And these two information streams come together in the amygdala. Now, I am intentionally not talking about the particulars of this path because there is a lot of controversy. In general in primates, but for visual information across many different species about whether this information really does go directly from the thalamus to the amygdala. There is not much evidence of that in primates, despite Joe Ledoux's slide here. What there is pretty good evidence in primates and humans is that there are two components to this capture of attention by threat. One of these is very quick, without much detail that we're not completely aware of, and one of them is more slow. And the output of these two processes ultimately engages that lateral ventral network, that yellow network that I showed you in the red-yellow slide. So we were just talking about the medial prefrontal amygdala connection. This is a lateral prefrontal amygdala connection that this behavior involves. So I've worked very closely, actually, with two of Dr. Andrews' students, Karen Mogg and Brendan Bradley. And the other thing besides conditioning that I've spent about 10 years studying, is really the human analog of bottom-up capture of attention. And this is a paradigm, I'll walk you through it, called the dot probe paradigm, that lets you look at bottom-up capture of attention. And much of my work in this area has either been done with Karen and Brendan or with Yair Bar Chaim. And Yair did a meta-analysis in 2007 and showed that there is a relationship between the amount of attentional capture, the degree to which that snake grabs our attention, and the level of anxiety. And Yair showed data in about 1,000 subjects, and there was a respectable effect size of 0.45. So the way that this paradigm works is, you can think of yourself as walking through the woods. You get a warning cue, and your non-emotional task is to say something about that probe, to identify it, to make an eye movement to it, to indicate the side that it's on, something not emotional. And what happens on some trials is an emotional and a non-emotional stimulus is presented, and based on the degree to which my attention is captured by this stimulus, I can say something about attention bias. All right? And there's a very clear, simple, nice story that anxious people have a greater attention bias than healthy people. And that's what their attention is more rapidly captured by this. There are two parts to the story, though, that get a little messy. All right? One is that the behavioral indicator that we use here is a very global index that belies the complexity of the process that goes on here, all right? And then the other is that performance on this task is highly plastic and highly responsive to stress. And I'm going to tell you a little bit about both of those. So the first one, we know that because if we vary the exposure duration of these faces, we get radically different findings. And that's pretty troubling. So in the data that we use and the findings that we get the most consistent findings if we show the stimulus for 500 milliseconds. If we show the stimulus for a brief interval of like 17 milliseconds, all right, and we mask it, we see no behavioral finding whatsoever, all right? But if we do this with evoked potentials, or if we do this with functional imaging, we do see individual differences, all right? So the first idea is that a lot is going on in this 1,000 milliseconds. So let me just show you a little data. So this shows you a bunch of studies. Karen and Brendan have done most of them, and all these studies use the same paradigm that I just showed you, and this shows you different studies use different stimulus durations of those faces. So the first thing that you can see is that this is a pretty robust, replicable finding. You see all these vigilances here at the 500 milliseconds. You don't see many at other times. Moreover, there are two studies, one that Karen and Brenda did, one that we did, where the same subjects have been studied with one task that directly manipulates these exposure durations. And in both of them, there was vigilance at the 500 millisecond, one in kids, one in adults, and there was no vigilance either at shorter or longer. All right? So the behavioral measure belies something relatively complex. The next thing that we did, we've done, again, a whole bunch of neuroimaging studies. I'm only going to show you data from two of them that talk about this complexity, all right? So if we take about 30 anxious kids, or about 15 are anxious, 15 are healthy, and we expose them in the MRI scanner to this 17 millisecond threat with this mask, what we see is no differences in behavior. We see a greater amygdala activation in the the anxious kids relative to the healthy kids, and there is a very strong positive correlation. The more anxious you are, the greater your amygdala activation is, all right, on the one hand. When we take another group of 30 kids and we do the paradigm with a 500 millisecond exposure, we see no difference in the amygdala. We see a difference in that yellow Brodmann area 47 ventrolateral prefrontal cortex. There is more activation in the anxious kids, but there is a negative correlation between the amount of activation. The moderately anxious kids have more activation. The very, very anxious kids do not. All right? And what this starts getting you to do is it starts getting you to think about this behavior, this bottom-up capture of attention behavior, and trying to map these findings onto a circuit. All right? So what it does is you can start thinking about in anxious children, well, this is a circuit that Joe Ledoux talked about. How can we think about this circuit? In particular, how can we think about this amygdala ventrolateral prefrontal cortex circuit? And in particularly, what is this thing doing? All right? And how does activity in this region relate to functional outcomes? So we think that this is a key component in competent attentional control. So when people learn how to effectively orient, particularly when they need to change their orienting, we think that they draw heavily on this ventrolateral prefrontal region, and it is that flexible engagement of attention that we think people with anxiety disorders really have problems with. And we think that the kids who have the moderate anxiety symptoms and increased ventrolateral prefrontal cortex activation, we think that that is a sign of compensatory function. Well, if that's really the case, what would happen if we were to treat anxious kids, right? They already have an elevated ventrolateral prefrontal cortex activation. If that's pathological, if we treat them, it should go away, right? If it's part of adaptation, it should be even higher, all right? So we did complete one study where we took a small group of healthy kids, a small group of anxious kids, studied them twice, got really good data, and we did find that both with cognitive behavioral therapy and with fluoxetine, there was a significant increase in this ventrolateral prefrontal cortex activation, consistent with this compensatory idea. The other thing I will tell you, though, is this study was just a killer. If you've ever tried to do one of these, really long, boring fMRI studies with little anxious kids twice, before and after treatment, so that was it for me. I'm not going to do that kind of stuff anymore. But the other thing that this does help you do is you can start asking very deep questions about what's the relationship between functioning in this region and this same behavior that we're looking at. Because we are looking at anxiety, but what we're really looking at is at threat orienting. So the other thing that we have done is we have used this paradigm in monkeys. And so we have done a very large study where, 32 monkeys, 16 and 16, who were treated for a year with either fluoxetine or placebo, taken off, and then they're studied when they're 4, so a year after they've been off fluoxetine, with this same paradigm. And it is looking like we are showing that fluoxetine, even a year ago, is beginning to look like it reduces the amount of orienting towards threatening monkey faces in these monkeys, which again is the kind of thing you can only do when you're really looking at a very specific narrow behavior, like the amount of orienting you're doing towards this face relative to that face. All right, so remember I said that one problem is that a lot goes on in that 500 milliseconds. So this is the last thing I'm going to talk about. I will warn you, it's pretty complicated, but I'm going to try to do justice to it. The other thing, remember I said that we think that this response is very plastic. And one of the really confusing things that I started to get in the first study that I did with this in 2005 is that I got threat avoidance. And why the heck are we getting threat avoidance? You really shouldn't get threat avoidance. So we've done a whole bunch of studies on this. I'm only going to show you 2 of them that are quite convincing. All of this work was done with Yair Bar Chaim, and I started talking with him around 2005, and why are we getting threat avoidance? I had ideas, he had ideas, he didn't believe it, but my idea was that attention bias is something that's highly plastic. And Tony and I were talking about the Yerkes-Dotson model. And in 2005, I will tell you, there's somebody in my group still makes fun of me that I say this, but I really do believe it, that there is an inverted U relationship, don't laugh, between how anxious you are and the nature of your threat bias, and that anxious people are shifted to the right. That is the thought. Under no threat, if they're not threatened at all, there's no bias. In healthy people, anxious people have a bias towards. There is a lower threshold in anxious people for engaging this threat system. So under mild threats, these people shift their bias away, whereas healthy people have a bias towards, and under extreme threats, everybody shifts their bias away. That was the idea. Yair thought that this was the craziest idea ever. And so, we talked about this from 2005 until 2008. He was with my group for about a year, moved back to Israel in 2008. And Yair is one of these crazy Israelis. I'm sure you have some around here who just his favorite thing in the world is to prove you that you're wrong. So he was just sitting there in Israel waiting for the perfect situation to prove that this idea was wrong. So, and he had an IRB form in just waiting for this thing. And so in 2008, in December, Yair lives in Yavne, and war broke out in the Gaza Strip, and people in the Gaza Strip started firing rockets into this area you see right here. So Yair said, this is just what I've been waiting for. Yair took all of his group, and they waited for the high threat days, all right? Where there was an announcement that went out that if you're living in the red zone and it's a high threat day, when you hear the siren, you have 15 seconds to run for your life before the rocket hits. If you're in the yellow zone, you have 30 to 45 seconds. If you're in this zone, you have 60 seconds. If you have that zone, you're out of threat. All right? So Yair took all of his students out on the high threat day, gave them all computers, got them all with symptom checklists, and they went into the field and they did the dot probe task with all these people in the middle of rocket attacks. And what Yair found, as you would expect, there was an increase in PTSD and depression and anxiety, as you would expect, because these people are under rocket fire, right? But there was an inversion of the threat bias. All right? So their threat bias was away. It was away from threat. It was not towards. All right? So that was moderately convincing. But, you might say to yourself, well, maybe these people were like this to begin with, right? So maybe that's what's happening. All right? So Yair is very involved with the Israeli military. So Yair, we started talking about, can we work with your soldiers? So Yair identified a group of 131 stress-hardy elite new recruits who were coming into the Israeli army, and they were all going to undergo a simulated torture exercise where they are taught to withstand torture, and it's very grueling, incredibly stressful. But of course, Yair, you already get the sense of the guy he is. This is another great opportunity, right, to try out his ideas. So what he got the Israeli army to do, everybody got an assessment of all their psychiatric symptoms, everybody got an assessment of attention bias, and he was going to take one of the platoons, and he would randomly select them, and he was going to assess their attention bias in the middle of this stress exposure exercise, right? And the other one, they were going to be assessed just the day before. The other platoon, just the day before. All right? So this shows you symptoms, all right? Time 1 and time 2. PCL scores go, these are the two groups. The one group that was studied way before and then the day before. So there's no change in symptoms. This is the group that studied a month before and during stress exposure. So as you would think, there's this big increase in symptoms. But more importantly, you see here, there's no difference here, but the stress group, again, orients their bias away from threat, all right, when they're under torture, all right? And then two last things that I'm going to say, because I am running out. Do I have 5 minutes? Yeah? All right. So then the other thing Yair did was he took 500 of these Israeli recruits, studied them over 2 years, studied their attention bias at baseline, studied their attention bias after 1 year, and studied their attention bias after 2 years, and identified those. Nobody had PTSD at time 1, so everybody's without PTSD. Identified I think it was about 80 people who got PTSD at some time after time 1, and then looked at how attention bias changed in stressed people who got PTSD and stressed people who did not get PTSD. All right? And so what you see is the people who get PTSD, they have an attention bias towards threat before they're stressed. When they get stressed, their attention bias flips. It shifts away. So when they get PTSD, they have attention bias away. Healthy people get an attention bias towards. All right? So this is then an incredibly complicated set of associations. The place that it gets relevant, we come back to this circuit, right? And we say, okay, what does this have to do with treatment, right? I just told you about two basic ideas, right? One is that it's highly plastic, right? I just told you about this. And then the second is it has both a cortical and a subcortical component, right? So what that tells us is that distinct treatment components may target distinct psychological and associated neural processes. So one of the things we do in attention control therapy, in cognitive behavioral therapy, is we focus on explicit processes. We tell patients, the example I always give, I'll give Anne, since Anne's so tough, that if I were an anxious person, they would say to me, don't focus on Anne because she's going to be looking all angry at you. And when you give your focus on Amanda, so I'm controlling my attention as an anxious person to look away from the threat, to look at the safe process. That is a slow, all right, so you're not so threatening. But so that is a slow, deliberative, cortically based process, we would think, all right? And that's really what CBT targets. That does not do anything, probably, we would think, to processes that operate much more quickly. So, how could we do that? How could we change these subcortical processes? Well, it turns out, as I mentioned, attention bias is highly plastic. We can take people and we can expose them to these kinds of tasks where they do a dot probe task, but we can randomly manipulate this target such that subjects are presented with hundreds to thousands of trials where this target either appears behind a safe trial or behind a threat trial. And when we do this, we can change the attention bias that people have. Colin McLeod was one of the first people to do this, and he showed in healthy people, with Yair, we started with studies in children, Colin worked with adults, that you can, it's not that great news, I'll warn you, you could take healthy people and make them more anxious if you train them towards threat. And there are about 15 studies that do this. We've done 3 or 4 of them. And if you train healthy people to attend to neutral stimuli, you don't change their response to a stressful experience. If you train them to threat, you do transiently elevate their response to like a public speaking task or a stressful anagram task on many different measures of stress. All right, well, what if you take anxious people and try to train their attention bias away, all right? And sure enough, these are results from 2 studies where patients are either trained, again, not by telling them anything, but by giving them thousands upon thousands upon thousands of trials where the probe always appears behind the safe stimulus, and they learn how to shift their attention. And there have been about 12 studies. This is a meta-analysis that we published just about a month ago that shows, again, not a great effect size and a lot of variability, but in anxious people, training away from threat repeatedly has a modest effect on clinical measures of anxiety. Now, Again, do I think that this is ready for prime time? Absolutely not. And would I recommend that you go out and do attention training with your patients? Absolutely not. On the other hand, we are starting to think of using what we know about the underlying neural circuitry to generate new ideas about how we might want to shape a specific behavior, not a symptom, but a specific behavior. I will tell you the story for a lot of the reasons. I won't go into the details, but the story is quite complicated, as you can imagine, and if people have more questions about it, I'll tell you about some of our other data, results, and struggles. The way I think about this, though, and this is the last slide that I have, the way I think about this, I did mention, see, everything comes around in the end. This is baseball, right? He's definitely not a Jewish kid. Does anybody know who that was? Who was that? Ted Williams, that's right. So when I was growing up, I loved baseball. This was my favorite book, The Science of Hitting, because Ted Williams really taught you how to be a great hitter. He was an amazing hitter. But the really interesting thing is when you read that book, Ted Williams said, and he was really just talking about hitting, but it's really any complex behavior. What Ted Williams said is, if you really want to master a complex behavior, there's two things that you need to do. First thing you need to do is you need to understand the behavior. You need to know everything about it, and you need to walk into the context where you're going to have to use that behavior being really knowledgeable. So for Ted Williams, it was the strike zone, all right? So he taught all of his hitters. This was his strike zone. When Ted Williams walked up to the plate, he saw that this was his batting average for these pitches. So he said he was really only, until he had 2 strikes, he was really only looking at a pitch in there. And this is, again, a slow, effortful, declarative process that he's thinking about as he walks up to the plate. When that pitcher goes into his windup, however, you are not able to rapidly deploy that information. So what Ted Williams said is, it's not enough to just learn the strike zone. The other thing you need to do is you need to practice over and over and over the act of swinging the bat, thousands upon thousands upon thousands of times, till it gets to the point where you can rapidly deploy it effortlessly. And it's only by combining these two things, it's only by really understanding the strike zone and knowing everything about hitting, but also being well practiced at that very rote behavior, that you can really be a good hitter. Well, maybe attention control and anxiety is the same way. It's very helpful to focus on Amanda and focus on Anne, but when I'm in the middle of this talk, particularly if I'm anxious, I'm not really going to be able to draw on all of that. We need to rotely practice very specific behaviors that are perturbed in the anxiety disorders if we really want to get to better treatments. All right, so I gave you I can't believe I finished all that in 40 minutes. There's a lot more I wanted to say, but I didn't. But hopefully I gave you a broad overview of the promise might be a little strong, but the excitement of neuroscience. I talked about 2 very specific behaviors. I talked about conditioning and I talked about attention. And hopefully the main thing that I conveyed is how complex and how far we have to come in both of these areas. So, when we think about, are we going to have diagnostic tests? Not anytime soon, at least using the technology that I use. On the other hand, the one area where there is really great promise is in novel therapeutics. We desperately need novel therapeutics, and what a better place to get it from neuroscience. So with that, I'm going to acknowledge my collaborators. The big one, do I list you? I do list Amanda. See there? Amanda will always be listed there. But really, Brendan, Karen, Yair, and Nathan did most of the attention work. Jen Lau, Eric Nelson, and Jen Britton. Where's Jen? And Jen Britton did most of the conditioning work. So thank you.
We have some time for questions. Is that you, Linda? Want to ask a question?
It's either a really good sign or a really bad sign when somebody has a question right away.
Hi there, that was a great talk. In terms of assessing a likelihood of response to medication rather than trial by error, I wonder if the method that you proposed of studying for looking for the novel therapeutics could also be used for looking at likelihood of a clinical patient responding to
So there's a lot of interest in that. I don't think that that's going to work. I don't think that that's really a good way to go. I think all the treatments that we have right now, and CBT might be a bit of an an exception, but it's definitely the case with medications. They are not anywhere near specific, and they're like bazookas to a fly, And so I think my personal feeling is that trying to understand what these treatments we have that are effective are doing, and then predict response from that is not a good way to go. The way that I think to go is to try to understand the basic underlying circuitry, to focus on behaviors that we know are abnormal, but to not be guided by what we know clinically, be guided by what we know about the brain, what are the, it's one of the, there are many times when it's not great to study anxiety, but one of the great things about studying anxiety is we do kind of understand the neural architecture. It is conserved across species. I think that's the way to go. I think, kind of trying to understand basic brain behavior relationships, using what we know about how to manipulate them in rodents and non-human primates to come up with new treatments, kind of along the lines. That's where I think the money is. Sure. Yeah.
This is a great talk. Thank you. Can you talk a little bit more about your conceptualization of the counterintuitive avoid behavior?
Oh, yeah.
Is this a compensatory, the system simply cannot process?
No. The way I would think about it.
How do you think about it?
Yeah, the way I would think about it is much like, and there's huge amounts of work on this on rodent fear response, that that there is a continuum that it's conserved across species in terms of the reaction to threat, and that when a threat is very distal, the organism either doesn't pay any attention to it, or maybe they monitor it. As the threat gets closer, they're vigilant towards it, they pay a lot of attention to it, they know exactly where it's going. As it gets closer still, they either flee or they attack it. When the threat is imminent, there's tonic immobility. So the organism freezes and does not respond at all. And it's a pretty robust, it reminds me, it's a little bit, if you ever saw Jurassic Park, I was telling the students, I'm a big movie guy, but there is the one scene where the guy's going to the bathroom and the Tyrannosaurus finds him, and the guy just totally freezes. And so that's what I think, that I think it's much like when people are traumatized, when they freeze and they avoid and dissociate. That's what I think it is. So you can think of it as a neuropsychological, attentional counterpart of dissociation or freezing.
Because there actually is a treatment modality in natural disasters and now being used with soldiers with PTSD in the U.S., run by a Brigadier General Laurie Sutton, which uses, essentially, you locate a positive resource in yourself. And I want to hear your reaction.
Yeah, it's interesting you say that. So, we've been doing a lot of these attention, I always love telling this story. We've been doing a lot of these attention training studies. And Yair, I wish Yair could be here because I don't know if he's funnier than me, but no, Yair's very funny. Yeah, I'm pretty funny. I think I'm pretty funny. I'm from New York. We all think we're funny. Anyway, so Yair has this great idea, right? We got all this attention stuff. He's a big military guy. So we go to the head of the Israeli Defense Force. We have this great idea, right? We're going to take all your soldiers and we're going to teach them how to not look at threats, Won't that be? Yeah, that's kind of.
This is in recollection.
Yeah. Well, anyway, so to make a long story short, there are a lot of problems, particularly with people who might need to pay attention to threat. There are a lot of problems in figuring out what to do, and there are things that we've done with that. But the thing that my group has done, since we've got very frustrated, worrying that we were going to actually harm somebody, right? And that story kind of makes that point, right? It's really obvious with the Israeli soldier why you don't want to teach him how to avoid threat. But even the anxious kid, right? You might not want to teach them how to avoid threat. So the thing that we're doing, and there is some evidence to show that this works, we are training people how to attend to positive stimuli. So we're training towards happy faces. And there is a fair amount of work that shows that that might be part of resilience, and we are doing that. And you don't worry as much about making people worse that way. The data are not quite as strong, but it's what we're doing. It is what we're doing, and we're doing it with CBT. So everybody gets CBT, and they're randomized to either get training towards happy or placebo training. So yeah, and there's a lot of interest in doing that. So, but the data aren't as strong. Yeah.
Is the positive stimuli external or internal?
External. Well, with his it's internal. With ours it's external. But I think the idea is you focus on what you attend to. If you're teaching people how to attend to an external positive stimulus, the idea is that it triggers positive associations internally. And, attention is the gateway to the mind, or the spotlight to the mind, And so if you're focusing on, think about the positive, right? It's for it to really change behavior in a lasting way. Marjorie and I were talking about generalization. For it really to generalize, it's got to, work on your kishkis, right? It's got to get in there, right? So the training is external, but we think it. And I will tell you, we train the kids. We tried all kinds of things figuring out how to train the kids. Now what we do is we train them as part of their CBT sessions, and we do see that the training stays. So if we train them this week, when they come back in a week later, they're still trained a week later. So we don't know if it works clinically, but we do that.
Thank you very much for a great talk. I'm just curious. You have Nathan's name up there, so it's an invitation to ask about your sort of, based on what's been discussion, sort of the underlying aspects of temperament.
Yeah.
So mice freeze quite readily, a species-specific defense reaction, where lions are a lot less likely to freeze.
Right.
So what do you think underlies some of that, the biology of temperament?
So I will tell you. Let me say 3 things about that. First thing is remember that right at the very beginning I said we think mental disorders in general, including anxiety disorders, are made of many different components. So if we were thinking about heart disease, maybe this talk was all about cholesterol, right? That's kind of the talk that I was just giving. There are whole suites of other things that relate to specificity, heritability, genetics, that we might think of as hypertension, right? I didn't talk about a lot of those, including temperament. So that's the first thing to say. Second thing to say is that I have a whole other set of work both about specificity and disorder versus risk. And actually a lot of this work is with Nathan as well. A lot of the attention stuff and a lot of the conditioning stuff is with Nathan. And a lot of that work focuses on some of these paradigms, but other paradigms as well. Probably the most relevant thing to say, and it relates to the question right before, so Nathan's anxious kids, the kids with behavioral inhibition, do show an attention bias towards threat, and they do show an attention bias towards threat very early in life. Age 5, they show that. However, if you look at, and probably the best study we did followed this one cohort through about 20. If you look at the kids with behavioral inhibition and you contrast the ones who do get an anxiety disorder from the ones who do not get an anxiety disorder, it's about half. About half of Nathan's kids get a clinically significant anxiety disorder. The threat bias does not relate at all. So the behavioral inhibited kids with anxiety disorders and the behavioral inhibited kids without anxiety disorders both have a threat bias. The thing that differentiates them is the happy bias. The anxious kids with behavioral inhibition have no happy bias. The non-anxious kids with behavioral inhibition do have a happy bias. So that's also, related to the work that you mentioned, but that's also where we got this idea of training towards happy bias. But, I think the bottom line is there's a whole suite of things related to intrinsic individual differences and related to specific kinds of threats, social threats in particular, how you respond to social threats that have very little to do with what I talked about today, and that's a big part of the risk and temperament story. That's probably doesn't relate to treatment, actually, but it does not really relate to what I talked about. So you had David last time said I made a big thing about a specific brain region. I think I was down on the amygdala a little bit. You gave me a really hard time. You're not going to give me a hard time about anything? No. Okay. All right. Yeah, Ann will give me a hard time. Come on.
No, I just want to give you a chance to comment.
there's a lot of interest right now in sensitivity to context and so forth, and you talked about plasticity.
Yeah.
Could you just comment on individual differences in plasticity? You also commented on how you could take a normal, typically developing person and drive the system toward one direction or not. I just wanted to hear your idea.
Yeah, sure. So when and again, I stay very kind of neuroscience-y, and we don't like to talk about things like context, right? The problem with context, there's always another context on top of the last context, right? So it gets to be a problem fairly quickly. I will tell you, though, that your ideas about context, which very heavily influenced me, when I think about plasticity and stability, it's very much about how behaviors change across contexts, right? And in some way, the absence of plasticity or the failure to deploy context-appropriate responses is one of the things that goes wrong in things like attention bias, right? So attention bias, if you think about that inverted U model, that's an example where you've got to shift your attention bias depending on the context of the situation. You don't have to worry about threats in low context. In a slightly higher threat context, you attend to them. In a really high threat context, maybe you avoid them, all right? Problems in making that transition is how I'm thinking about plasticity. The problem for it neuroscientifically, context is very hard to manipulate. So we do virtual reality studies where we did a whole big context conditioning study actually with our screen, and we could show context conditioning to a room where the screen was paired, but it's very hard to do. And particularly the way you talk about context, with these nested contexts, it gets very hard. The other thing about context is the effects are when you look at threat and fear, the effects are weaker than the effects of overt threats that you present in the context. So that makes the work hard to do. What was your second big question?
I just wanted to know about your thoughts on plasticity and
it's a good thing.
In terms of its, well, I'm wondering about the individual differences.
Oh, well, so it is true, and you might have even done some of this work, that there are very large individual differences in terms of how easy it is to train attention bias in people. That some people train very quickly, and other people don't train so quickly. And it's the same thing with fear conditioning. There are very large individual differences in terms of how easy it is. When we do fear conditioning with non-human primates, some of them learn, boom, others of them, you don't think that they're capable of conditioning. The interesting thing is those individual differences, particularly in learning about threats, don't look like they relate to clinical anxiety. So when you look at rodent models of anxiety, the rapidity with which the organism learns about threats doesn't relate all that strongly to individual differences in rodents in anxiety. The thing that really relates to individual differences is kind of these subtle threats. So if you use that pigeon paradigm, if you look at the response to the red light, the anxious rodents are just like the calm rodents. It's the response to the green light. That's where the calm rodents don't respond at all. The anxious rodents, have a very big response. So, which is consistent with that, classification idea. I would have talked longer if I knew.
Very much.
Sure.
So my question is a little bit like a springboard off of what you were just saying. It seems like there are a good number of people who seem to develop either PTSD or panic disorder or phobia just on, seems like one exposure to a very scary, traumatic situation. And I wonder if it's has something to do with a predisposing risk. Like you talked about the breadth of the reaction to the conditioned stimulus, and maybe they were kind of one of those individuals who was predisposed to have a a reaction just on one exposure?
Well, kind of like related to the question about temperament and individual differences. I do think that there are very robust, interesting, stable, strong individual differences in response to overt threats that probably don't have a lot to do with learning. All right, that I think that there's just a lot of individual variability in the way that people respond to intrinsic dangers. There is individual variability, and it's quite stable. Sometimes it relates to pathology, sometimes it doesn't. It's quite disorder or stimulus specific, which I find really interesting. And you hear from patients all the time. They're scared to death of this thing, but they're not scared of anything else. And again, it's really interesting. But a lot of that does not have much to do with experience. It's kind of like what you're born with. So my take on this, PTSD phenomenon, or why some people get PTSD in this situation or not, it's some combination of it just so happens that this experience, for whatever reason, was in your sweet zone in terms of the things that you're intrinsically vulnerable to, or the things that you respond more to. Obviously, for example, I don't respond to social. I'm not socially anxious at all. But there are some things that get me just ridiculously anxious. And if I happen to be unlucky enough to be traumatized in one of those ways, in a situation that's just based on who I am, that I'm going to get PTSD. Whereas, so some of it's just luck, right? That there was resonance between the nature of the trauma and the nature of your vulnerability. Others of it is there are just kind of like I was talking about here for anxiety disorders, there are common vulnerability things in PTSD, intelligence, cognitive control, the nature of the stressor, right? If there, it's a particularly bad stress or particularly extreme, that probably don't relate to individual differences. So, yeah. Those things are really, I got to say, the intrinsic, things that you're afraid of independent of experience, it's really interesting, and particularly conspecifics, why some people are so afraid of other people. And you see that very early. I mean, that's the really interesting thing about Nathan's work. You can identify, within the first months of life, people who are going to be particularly afraid of other people. I mean, it's amazing,
One could argue that's evolutionary lag.
Yeah, maybe. Or, maybe there's you need to have variability because in some contexts, those kind of people might be tremendously successful, right? That it still might be adaptive in some ways, right? So.
One last question here.
Hi, I'm interested in how attentional biases for threatening cues can spill over into memory biases for the.
Oh God! So that is one of the really interesting things is that there's this huge disconnect, right? That anxious people have this attention bias towards threat, but they don't have a memory bias. Why is that? You should remember things better that you attend to. So if you attend a threat, you should remember threats better. Anxious people don't have that. My thought on that, because we've done a lot of this work with anxious and depressed kids, and we see that in kids too. Depressed kids have a memory bias. They don't have an attention bias. Anxious kids have an attention bias. They don't have a memory bias. And my take on it is, it has a lot to do with memory consolidation. That a lot of the processes that go awry in depression have a lot to do with kind of rote, repetitive, ruminative kinds of psychological, that core psychological responding process. It's a ruminative process that tends to be very helpful when you're encoding a stimulus because it really consolidates it. The psychology of anxiety is kind of all about orienting and monitoring your environment and dealing with threats and then responding to them. There's not a lot of psychology about consolidation. It's not part of the problem. It's kind of more in dealing with the environment that's out there, and less about, oh God, now what am I going to do now that that's the other really interesting thing about anxious people. They tend to do really well under real threat. That's the other clue that, and my patients always say that to me. I don't understand it. Whenever I'm in a really dangerous thing, I was in war and I was totally fine, or I took this exam, but if I really flunked it, they're fine in that situation. It's kind of in these subtle dangers that they have a harder time with, and it's more in the initial response to it, not as much as in the consolidation. So, all right, good to see you all. Thanks again.
The UC Davis Mind Institute began in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, learning disabilities, and other brain disorders is helping children achieve their fullest potential. Please call or visit our website to find out more about current studies, our research team, and upcoming events.